Now we're going to stay with the neonatal theme, and we have 3 presentations, 2 from Ethiopia and 1 from Uganda. And we're going to start with Mulugeta Shigaze, who's from the Arba Minch University in Ethiopia, and he's going to talk to us about community-based essential newborn care practices and associated factors among women who gave birth at home in the last 12 months in Amaro, southern Ethiopia. So over to you, Mulugeta.
Okay, thank you. I'm going to present this title, Community-Based Essential Newborn Care Practice and Associated Factor among Women Who Gave Birth the last 12 months in Amaro district. Amaro district is one of the hardest to reach area, and but the national government has many community health workers. We call it health extension workers. There are health extension workers who are providing awareness on essential newborn care. Next slide. And the one that initiated us to conduct this research is just many women are giving birth in the home, so they should have practice, community newborn practice. So, but the level of and the factors that are associated.
Oh, seems we have lost you, Mulugeta. Well, maybe if you try shutting off your video, we can see your slides, and maybe that might work. No, I don't think we can hear you anymore, Mulugeta, which is a real shame. I don't know if you seem to have come off screen. I would therefore, for now, we'll chat with you, Mulugeta, and see if we can get you back. I think I would suggest now moving on to the next speaker. I'm just looking for feedback from my colleagues. Yeah. Okay. Right. Sorry, everybody. There is no virtual meeting without something going wrong with information technology. So this is our first hiccup. If it's okay now, I will move on to our next presentation, which is by Liya Assefa, who is from Gol, and she is also based in Ethiopia. And she's going to present to us on the use of educational videos to improve maternal breastfeeding knowledge and practices. So we will have to switch forward on the slides and come to Liya's slides. Is that okay? And Liya, when you see your slides, please start speaking. Thanks.
Thank you. It's visible. Okay. Hello, everyone. I'm Liya, Senior Nutrition Research Officer in Gol Global, based in Ethiopia. And this is a presentation on the main findings of a pilot study, which was conducted in Ethiopia, Gabella refugee camp, with the aim of assessing the change of breastfeeding knowledge and practice after the provision of breastfeeding educational videos. Next slide, please. So nowadays, use of educational videos has become an effective approach of health education in improving knowledge and practice towards breastfeeding. So by taking this into account, Gol has started using these breastfeeding educational videos in its existing IYSF and MAMI programs in order to address the barriers faced by breastfeeding women during the first 6 months of child's health and child's life. So in order for this pilot approach, Gol has translated 8 health global media projected on breastfeeding to the newer language. It is the language of South Sudan refugees, which are reside in Kule and Turkey refugee camps. So the overall objective of this study was to assess the impact of the breastfeeding educational videos on the maternal knowledge and practice, and also to assess the acceptability and utility of the educational videos by the community and also by the health workers. Next slide, please. So in terms of methods and assessments, the study population included were mothers of infants under 6 months, and at the baseline, mothers with infants under 4 months reside in Kule and Turkey refugee camp who attend the IYSF and MAMI program, and also at the same time receiving breastfeeding counseling were invited. We used an education evaluation design with longitudinal data collection at the baseline and also at the end-line assessments, and this is due to the COVID-19 pandemic. Next slide, please. So for this assessment, this slide shows the study flow. And for this assessment, a total of 96 participants were selected who were attending the IYCF and also MAMI programs. The mothers were shown breastfeeding videos over a period of 2 months, which were from August to October 2020. And it was on a one-to-one basis. On average, each video lasts for 7 to 8 minutes. And the video were shown based on the mother's breastfeeding challenge and preferences. So by the counselors, it would be decided the sequence of the videos, and the videos were repeated if required. And over a period of 8 weeks, the participants were shown all the 8 videos that are translated into their local language. And finally, at the end line, we used both qualitative and quantitative tools, a semi-structured questionnaire, a focus group discussion with the mothers, and also key informant interviews with the IYSF and the MAMI and IYSF counselors. So based on this, we have identified the primary and secondary outcomes. So for the quantitative study, the primary outcomes were exclusive breastfeeding, bottle feeding, cup feeding, knowledge of early initiation, and also knowledge of complementary feeding. For the secondary outcome, advantage of early initiation, attachment and position, signs that the baby is hungry were identified for the quantitative study. And for the qualitative study, around 6 outcomes were identified and assessed: utility, appropriateness, acceptability, effectiveness, challenges, and suggestions. Next slide, please. So as you can see in the figure, based on the analysis, the primary outcomes demonstrated a statistical significant difference in knowledge about the introduction of complementary feeding, which increased by 8.7%. You can appreciate in the table in the last line. And however, there was no significant differences were observed in the primary outcomes in breastfeeding practice and knowledge, and it is because of at the baseline itself, all mothers were already practicing exclusive breastfeeding, and similarly, majority of the mothers at baseline already had correct knowledge about early initiation of breastfeeding. You can appreciate in the first line, which was in the pre-assessment, it was around 100%. In the analysis of secondary outcomes, unlike the primary outcomes, there was a substantial change in knowledge. There was an improvement in knowledge about advantage of exclusive breastfeeding, attachment, positioning, and also signs of identify that breastfeeding, that the baby is hungry. So in order to illustrate some, mother's knowledge about identifying signs that the baby is hungry has also improved. Initially, they could only identify moving tongue or lips and crying as a sign of starving, but after exposure to the interventions, they were also looking for signs of opening mouths and putting the hand into the mouth. Next slide, please. So in terms of findings in qualitative outcomes, which is very interesting, in utility, both the mother and health workers found videos useful, and one of the health workers also highlighted that with only counseling, it was difficult to demonstrate, and she phrased it that we don't demonstrate everything because it's hard to show our body private parts. And similarly, another health worker also mentioned that it reduces their workloads. So in terms of appropriateness, both mothers and health workers said the videos were comprehensive, and they also appreciate the translations. In terms of acceptability, there was no report of dislikes, and mothers shared various examples of what they like about the videos, such as they said they can practice while watching the videos, they like how real the videos are, and found them easy to follow and also remember. In terms of effectiveness, mothers said videos were more advantageous than simple counseling, and they also highlighted that when they watch the videos, it is easier to practice and also remember the message. So with standard counseling, they sometimes tend to forget. On the other hand, health workers also said convincing mothers to participate in counseling requires much effort. So one of the health workers also said that counseling takes more time and sometimes beneficiaries tends to get bored. However, with the videos, they are happy to learn. So on the other hand, mothers also said that after watching the videos, they have started practicing expressing their milk and also storing their milks and observing signs that the baby is getting enough milk, and observing attachment to the nipples has also been improved. So they also say that it reduces their workload and their responsibility at home. And one mother also said that I learned how to express the milk from my breast, and this is a new thing. We have so many responsibilities as a woman. Knowing this method has helped me reduce my burdens. So in terms of challenges faced, expressing milk was not commonly practiced because older families were resistant to change this practice. And one participant has also said that the influence is high from their fathers and mothers. They want to raise our children as we grew up, and they refuse us to practice some of the practices we learn from here. So, for example, removing the milk from the breast is not acceptable by the community. So this was one of the challenges that they felt. So next slide, please. So in terms of limitation, due to the COVID-19 pandemic, we use an educative evaluation design. So the data we collected were brief and the investigation were not as detailed as would have been planned under normal circumstances. And with this design, it might be difficult to infer that any observed changes were due to the intervention, since there is no control group to ensure these changes would not take place anyway. So next slide, please. In summary, we have found that after watching the videos, exclusive breastfeeding was sustained and there were improvements in more detailed maternal breastfeeding understanding and knowledge. Both mothers and health workers found the videos acceptable, useful, and effective. For way forwarders, we are planning to expand and implement this video-assisted counseling in both our IYCF and MAMI programs. And we also are considering to increase the frequency of watching the videos, enhance the size of the screens, and we are currently using a tablet, and also invite other family members like the husband, grandmothers, pregnant women, and other community members. So this is our presentation. Thank you.
Great, thank you very much. It was a quick presentation. So just a reminder to the speakers coming after you to keep speaking at a slow pace, but it was really exciting what you did in Ethiopia. And it's exciting that you are planning to scale up. One of the questions that we received was, how do you see the challenge of scaling up? Because in a resource limited setting, taking videos everywhere and showing videos is quite technically, maybe technically challenging. So we were just wondering how you managed to do that.
Okay, thank you. For now, what we are doing is that we have an existing structures, the IYCF and the MAMI programs. And on March, we also have given the training for other implementing partners, other NGOs, in order to expand our activities on also these global health medias related to family MUAC approach also. So what we are planning to do is that there are mothers, pregnant mothers, and also lactating mothers who are attending our IYCF programs. The challenge that we are facing mainly is we are using a small scale-sized tablet, which can be shown for only 1 or 2 mothers. And due to also the COVID, we are not able to use the screen for multiple pregnant or lactating mothers. So what we are planning to do is, in order to expand that and also get a bigger picture, like something with a television, with high scale television with the screens, so that many mothers can watch and also share their experiences one-to-one on there.
Great, thank you. We had another question about the mothers. They gave you good feedback on the video, did they give you feedback on what is the best way to improve care? So the video is one way, or did they give you any other feedback on what you could do better as an organization?
Yeah, what they said is that because primarily one of the challenge was that the older population or the older community inside their house, especially the grandfathers and the grandmothers, were not approving, especially storing the breast milk. So that one of the challenges that they faced was that. So what they recommend us to do is that they want us to expand our programs and involve not only the lactating mothers, but also other family members, the grandmothers, because mostly the woman or the mother herself have responsibilities at home, like fetching waters, collecting firewood. So the caretaker would be another person, like their grandmothers. So in order to change the behavior and also the attitude, they recommend us to include the other family members, the husband and also the grandmothers, to this program.
Great, thank you. That's very interesting. And just a quick clarification question: which videos did you use? Was there something from the internet, something you developed?
We take this educational videos from the Global Health Media Project. These are educational videos on breastfeeding. So they are available on YouTube for everyone. And we take that and translate them into newer language. So anyone can access these videos on YouTube in Global Health Media Projects.
Great, that was really useful to know. Thank you very much. We're now going to go back. I understand Mulugeta is ready to speak to us again. So I'm going to hand the floor straight over to you and hope the internet works for you this time.
Okay, sorry for the interruption, and just let me start with statements of the problem. And as I told you, that the community-based newborn care means bring life-saving care to the community. That's why we are led to conduct this research in that community. The community is very hard to reach community, but there are community health workers. We call it health extension worker. But we don't know how many of the women are practicing community residential newborn care and the factors that are attributing to the level of the practice. So this led us to conduct the research in that community. Next slide. The aim of this study was to assess the prevalence and the factors that are attributing to the essential newborn care practice among the women who gave birth at home. Many women are giving birth in the home. They are not seeking institutional health. So far, we aim to conduct this research. Next slide. We used a method that our cross-sectional study design has been implemented, and randomly, first we conduct the small survey to know which women has been give birth in the last 12 months. Then randomly we selected the study participant to this research. Data was collected using a standard and validated tool. We validated the tool in that community. And first of all, we have adopted the tool from WHO and other journal, which has been published in reputable journal. And then finally, we validated the tool in the context. After the collection of data were entered using AP data version 3.1, and which is translated to transferred to the species version 20 for analysis, and every statistical procedure has been conducted, and bivariate and multivariable logistic regression was employed to analyze the factors. Next slide. Accordingly, 29% of women practicing home delivery, they practiced essential newborn. The others were not. To know the factors that are attributing, we have conducted multi-level logistic regression. Accordingly, we found education, the education of the family if the family educated, they were 2.28 more likely to practice essential newborn care than the counterparts in that community. So you can acknowledge education is very important. This finding, however, this finding is consistent with the study done in the many parts of Ethiopia, including Bangladesh. The other finding that we found from the multivariable logistic regression was the last delivery assisted by relative. If the relative is assisted, if they were assisted by the relative, they were 3.58 times more likely to practice newborn care in the community than the counterparts. Maybe due to the poor quality of counseling by community health worker or the health development in the community. So this needs an attention. And the next slide. Having awareness about the community-based newborn cares were important, and we found that 3.49 times more likely to practice essential newborn care than the counterpart. If the women have awareness of the essential newborn care practice, they have the high probability to practice that care for their newborn than the counterpart. So awareness is one of the finding in this study. This finding was consistent with the finding in Eastern Tigray and Ethiopia and Gojam. So this is supported by another evidence. Awareness about newborn danger signs from the family. The finding in this study consistent to be in line with the community-based study conducted in Igu State, Southeast Nigeria, and Northwest of Ethiopia. Again, this finding may be due to the fact that the mother had neonatal danger signs may experience the counterparts. Next slide. Next slide. In conclusion, around 71% of the mothers who gave birth at home and practice in this study area were not practicing essential newborn. This is a large or a huge number, so this needs an attention. Therefore, promotion of information at the community level, women empowerment, and strengthening health extension program are recommended. So the national government should work on this, and this is all about our presentation, and thank you.
Great. Thank you, Mulugeta. And we kept the internet connection, which was always a bit nerve-wracking. So well done. One question. I mean, this is incredible information that you've collected, and also quite shocking, and well, not maybe that shocking to the audience, but that such a huge number of women don't practice essential newborn care, which is quite straightforward. And you've got some really interesting information on why that is. And I was just wondering how you're going to use this. I mean, what is going to happen with this information? Do you know the next steps that you said the government, but how are you going to give this, maybe even this information back at the community level? What are your next steps now that you've got all this knowledge?
Okay, thank you. First, this research has been conducted among the women who gave birth in the home, not in institution. So many of the women who gave birth in the home, it's because of lack of access. It's because of the lack of access, maybe because of hard to reach area. So there are health extension workers in that area, in hard to reach area. but they may not provide adequate information to the community, and there is a lack of awareness about essential newborn care in the community. Even we are communicating this finding with the government. We are as university, we are trying to provide community service for that area. The just a true number, and we found it using a validated tool, and we supported with a statistical approach. And so we are just working on that. That is
great. Thank you. That's really that's interesting, and is actually the point that you're making about the community support. And we have a whole session this afternoon, or in session 2, we're going to talk about community work. So it'll be nice to bring that together. Great, thank you. We're now going to move rapidly to another country. We're moving to Uganda. And if we could get to the next slides from Mårten Larsson. So Mårten Larsson is from Queen Silvia Children's Hospital in the Paediatric Department in Gothenburg, Sweden. And he's going to be talking about oxygen saturation during resuscitation. So straight over to you, Mårten.
Well, thank you, and hello, everyone. I'm happy to be here. And as you said, I'm a pediatric resident in Gothenburg, Sweden, and I've done a couple of field missions also with MSF. But now I'm here to present some data from a study with the title Pulse Oxygen Saturation during Neonatal Resuscitation in Uganda. And this data is yet unpublished, and we therefore wish that the content of this presentation should not be shared other on this session. The rest of the names you see are the team who worked on this together. Next slide, please. So there is consensus that neonatal resuscitation should be initiated using room air for term and late preterm neonates, since evidence showed that short-term mortality is reduced when initiating resuscitation with room air instead of 100% oxygen. It is also recommended to use pulse oximetry to titrate oxygen therapy and meet oxygen saturation targets that are based on SpO2 measurements in healthy neonates after birth. This practice is supported by clinical consensus, but no studies have explored the optimal oxygenation level in the first minutes of life for neonates that are in need of resuscitation. In low resource settings, the availability of blended oxygen and pulse oximetry is scarce and not included in guidelines aimed for this context, such as helping babies breathe. Next slide, please. But the availability of oxygen in Sub-Saharan African hospitals seems to increase. And in 2018, MSF and fellow neonatologists suggested a novel mid-level resuscitation guideline, which included oxygen to reach pre-ductal saturation targets. There are few studies on SpO2 in resuscitated neonates, and to our knowledge, there is no study from Sub-Saharan Africa where most births and the highest mortality occur. Next slide, please. So the objective of our study was to investigate SpO2 in neonates during resuscitation according to the Helping Babies Breathe algorithm and compare this with SpO2 targets. Next slide, please. So how did we do this? This was a cross-sectional observational study conducted as a sub-study of the new Supra trial at the Mulago National Referral Hospital, Uganda, the largest public hospital in Kampala. In this sub-study, neonates were included by convenience when the research physician was available. Inclusion criteria were inborn neonates, estimated gestational age above 34 weeks, estimated birth weight above 2,000 grams, need for positive pressure ventilation at birth, and parental consent. Exclusion criteria were any major malformation and stillbirth. After termination of positive pressure ventilation, neonates could receive oxygen by nasal cannula if they were assessed by the midwife with breathing difficulties, according to local hospital guidelines. But this was not guided by SpO2. Data were collected between January to August 2019. Next slide, please. So study procedure. All neonates were taken to the resuscitation table, and SpO2 and heart rate was monitored. All resuscitations were recorded on video, and the picture you see, it's a still frame from one of the resuscitations. Those videos were later reviewed, and data points were registered for every minute. The parameters could hereby be reliably assessed on the video for signal quality and timing. Next slide, please. So totally 68 neonates were initially selected and 49 included in final analysis. The birth weight median was 3,100 grams, APGAR score median 367, which implies signs of asphyxia. Mortality at 7 days follow-up was 20%. So this was a sick population, but concordant with the new SUPRA trial. Next slide. So what did we find? Here we see a box plot of all SpO2 observations during positive pressure ventilation at each minute. None of those received oxygen during PPV. The dotted line shows American Heart Association, AHA, SpO2 lower target range, and parentheses shows obtained and possible observations. And we can see that the median SpO2 were below AHA target at all time intervals. 83% of observations at 5 minutes and 67% at 10 minutes were below AHA targets. Of interest is also that 21 neonates received oxygen supplementation after PPV because of difficulty breathing. And out of those, 33% had SpO2 above 95% at 10 minutes. And this indicates need of weaning oxygen. Next slide. So strengths of this study were that video reviewing allowed for very reliable data, and it was performed under real-life conditions in a big hospital in Sub-Saharan Africa. Limitations were limited numbers, so it's hard to draw any sharp conclusions, and we suffered from some missing data, especially in the first minutes of measurements. Next slide, please. But still, our data show that the majority of resuscitated neonates failed to reach the SpO2 target during positive pressure ventilation in the first 10 minutes after birth. And this implies an increased risk for hypoxic ischemic encephalopathy. Further studies in low resource settings are needed on saturation levels at birth with long-term follow-up on mortality and neurological outcome, with the final aim to find optimal saturation targets for asphyxiated neonates. In the meantime, oxygen should be administered with care if available. Next slide, please. Some take-home messages for MSF would be that access to pulse oximeters and education on their use should be mandatory to guide oxygen therapy during neonatal resuscitation. And the fact that 1/3 of neonates in our study that received oxygen after positive pressure ventilation, they saturated above 95% at 10 minutes, it implies the need to wean oxygens. And this highlights the risk of hyperoxia when oxygen therapy is used without guidance of pulse oximetry. We also recommend MSF to push for development of easily accessible oxygen blenders to aid rapid and effective oxygen adjustment during neonatal resuscitation. Next slide, please. So thank you. That was all I had to say. And if you have any questions, I will be happy to try and answer.
Fantastic. Thank you very much. A very interesting review. I'm going to ask my questions. You emphasize very well that we can give too much oxygen. And we talked about that in the morning session as well. How it's a very difficult thing. It's a major behavior change. And given that you've been working so hard on this, have you had any shift? What have you done to change behavior? It's not just the numbers, it's also that behavior to respond to the numbers so that you're not giving too much oxygen and causing harm. So what's your experience on that?
Well, speaking from the study, I think we have actually just observed the hospital, the conduct at the hospital. Normally at this hospital they give oxygen just by assessing the breathing and not looking at the SpO2. So they were not trained in that. But I have experience also from MSF projects where I think this is also have been a problem, and where we really need to have trainings on how to use the pulse oximeters and when to wean. It's easy to apply something, but it's sometimes harder to withdraw. And I've seen many times children that have been lying with 100% oxygen for hours after birth, and this is not good, and we know it.
Great, thank you. I'm going to give you two questions in one go. One is, someone's asked if you could maybe elaborate what you think would be the most valuable next studies. And I'm going to squeeze in another one of my questions. Sorry.
Yeah, I think
sorry, go for it.
Yeah, I answer. In short, I think we need to make a bigger observational studies. This was a small study, and those needs to be done both in a high-income context to see the feasibility to reach those targets with oxygen, and but we know that oxygen is increasing in access in other settings as well. So we need to know how are they saturating before we implement something new. And in the long run, I think to answer what is the optimal oxygenation level, I guess we need to make randomized trials with different modes of targets and maybe modes of giving this oxygen to see what is the best way, and look at the long-term outcomes also.
Great.
This is ethically tricky to do, so but maybe not impossible.
Okay, the questions just came in, so I won't ask my question. Some maternity departments still face poor quality similar question of helping babies breathe. Would you recommend measuring oxygen, SpO2, and oxygen management to these places? So in fact, I have my question related to that was, you also saw a whole bunch of videos of resuscitation, which are really precious. So, you know, were people able to deliver effective positive pressure ventilation or helping babies breathe? And yeah.
I think really here, I would like also to say that I like the title of this session, Back to the Basics, because I think this is in a way step 2 to go and give oxygen and measure SpO2. I witnessed quite many difficulties in starting with the PPV in time to respect the golden minute and really work hard to start with PPV and not suction too much before PPV, because the babies, they need air. And we give them air with the bag and mask and not by suctioning.
That's a nice way to end. And you are, in fact, now ending the whole neonatal section with ending with back to basics. So what a nice way to end the session. Thank you to the first 3 oral abstracts. I'm now very excited to move to the next section, which is an interesting journey from one of the hottest topics, fluid management. And we also have really interesting data on mortality and training in life-saving skills. But we're going to start with fluid management, and I'm going to introduce Kathryn Maitland from Imperial College Paediatrics in the UK. And she's going to talk to us about Gastro. There you go, a phase 2 rehydration study for severe dehydration, Plan C that you all know versus slow rehydration. Welcome, Kathryn, the floor is yours.
Thank you very much. I'm dialing in from South Africa, so I hope everybody can hear me. Yes, I want to start by acknowledging the teams who were based in Kenya and Eastern Uganda for conducting this pretty tough trial, and also obviously all the parents and the patients who went into the trial. So yes, is this a hot topic? Well, I do hope it is a hot topic. Do I advance the slide myself? Sorry, next one. Yes, gastroenteritis still remains a major cause of childhood mortality worldwide. And obviously a lot of that does happen in the community, but there's still a lot of children being hospitalized with severe diarrhea and severe dehydration. And a very large case control study has shown that if you have gastroenteritis compared to any other admission, you're 8.5 times more likely to die than any other admission. So that's actually says quite a lot, given the fact that a lot of other conditions cause mortality during hospital admission. So when do these admissions die? This was a large study looking at cases controls, and it actually sectioned children into 3 sort of domains. The first domain is the first 7 days, then up to the next couple of months, and then beyond. So fatalities occurring throughout that period, but a third of the fatalities will occur within the period covered by the hospital admission. So it makes you ask the question, are the current treatment recommendations working in practice? Next question. Next slide, sorry. So we actually then, this is always the basis of me designing trials. So what is the evidence? So first of all, we were going to just try and look at what the evidence, and there were the trials that had been conducted and intravenous rehydration, and we were just going to look at LAMNCs, and realised that there was no studies, there was no trials. So we actually then had to widen it out, and worldwide there has only ever been 3 studies with a total of just over 450 patients. Most of those were looking at early discharge, where there's a slower or faster rehydration, but none of them had any deaths. So actually none relevant to the situation in which we manage patients. Next slide, please. So what is Plan C? And if you actually read the guidelines, which is what we do when you're designing a trial, saying what do they actually say? So obviously this is the hospital for what we would call the blue book, the handbook. First of all, you start off at the triage page where they're identified children with severe dehydration. So then there's their shock management if they have shock. Then obviously if you've got SAM, you have a different shock management. Then you've also then got to then relook at the children after the shock and possibly give them more fluid. Then you come to the rehydration pages, which is chart number 13, Plan C. So actually, if you followed all of the critical steps, children would be getting, and this is, remember, I look at the hours, this will be over either an hour and a half or over 2.5 hours or 5 hours if you're under 1. At 100 to 130 mils per kilo. If you actually followed the guidelines and didn't subtract what you'd given as boluses, which is very, very subtle in the charts, you have to read it in great detail, you would actually be giving children up to 160 mils per kilo over that relatively short time. But then look at that little caveat at the bottom. It says what you need to do is repeat the whole rehydration strategy if they still have a weak or not detectable pulse. So none of this has been tested. Why am I bothered about this? Well, we did a fluid resuscitation trial. I'm sure people will have heard of it, fluid expansion as a supportive therapy, where we showed being aggressive with fluid rehydration or resuscitation is potentially harmful. So we wanted to say, well, because you have 2 different rates, you've got your early phase and your later phase in terms of rehydration, can't we just simplify this? Next slide. So this really was the basis of our trial. We compared against standard of care and children who followed these what we call Plan C, but also all of the other aspects in terms of fluid boluses. Or can we just do slow rehydration, doesn't matter what age you are, replacing what we think they've lost, 100 mils per kilo, i.e. 10% dehydration and no boluses. Can we implement that safely? And that was the major sort of primary endpoint. Next slide, please. So these are the baseline parameters of the children who were in the trial. As you see, let's look at the second slide. Most children were less than 1 year old. That's the median age. They obviously had signs of severe dehydration, either one or more. A modest number of children had a number of signs of shock, but obviously you had to have WHO-defined shock before you could have a fluid bolus. Let's look at the laboratory features, and what we found was quite interesting, that quite a number of children had hyponatremic dehydration. Now, this is in other parts of the world that this has a different protocol for which you should manage this, but this hadn't been anticipated. So quite a high number had hyponatremic dehydration. Next slide. So were we able to follow what the rates were meant to be given by WHO? Remember, the WHO had the two different arms, under 1 year old and over 1 year old, and then you've got your Gastro SAM. We're looking at 8 hours. So they all get to what they needed, 100 mils per kilo by 8 hours. So yes, we followed what the recommendations were. It was very, very hard to get the teams to do this. And pragmatically to do this, we had to bring in perfusers, which is not pragmatic in the more general sense, to ensure that they followed the actual WHO Plan C accurately. Next slide, please. So remember, this was a safety trial. Can we safely implement slow rehydration? And as you see, overall, what we called severe, serious adverse events, including death and obviously a life-threatening event, we found relatively few, and of the ones who had died by discharge, there was relatively few children. So in both arms, and we just categorised those by the type of actual events that we actually saw. Next slide. So we were reassured, compared to standard of care, that slowly rehydrating children appeared to be safe. These are our other secondary endpoints. These are the type of things that are saying that, you know, how long does it take for children to tolerate oral fluids? That's panel A. Panel B, correction of dehydration. These are clinical assessments of dehydration. Time to pass urine, which is much more meaningful. We were able to monitor their urine output. And then obviously time to discharge. Though the bottom line for all of these, there was no difference in children having slow rehydration compared to WHO Plan C. Next slide. So we were able to, because we brought children back at day 7, we were able to say we had their weight at the time of admission. We also had the weight at day 7, and we estimated that weight, given the fact that they've now rehydrated, etc., that was probably their pre-morbid weight. In other words, their weight before they'd lost all the weight from dehydration. And remember, we're targeting 10% dehydration, and actually only 30%, a third of children, actually had what we could have suggested as 10% dehydration at the time when they were admitted. So that's quite an important point. Next slide. So the conclusions, I mean, we were surprised to see the hyponatremic dehydration, although I know it's not pragmatic to measure, but we do need the consideration of that. The signs of dehydration, lots of papers written on that, they're poorly, but remember, this is a very aggressive rehydration regime for just intracellular loss. This is intracellular loss from diarrhea, remember. So can we justify that? We found that slow rehydration was safer and much easier to implement than Plan C, and we didn't have these two different rates for different groups of children. We required a lot of monitoring and retraining to get the teams to follow Plan C. And what we would like to do in future is a phase 3 trial with mortality as the primary endpoint. Thank you. Oh, sorry, the trial is published in all its glory, but there's also there's an indication that this actually affects biomarkers, whichever arm you go into. There's an increase after rehydration, and it stays all the way through day 28, but I'm not going to talk about that. I'm talking about the clinical aspect, but there is a physiological marker that this is really stressing children's myocardium. Thank you.
Great, thanks so much, Kathryn. That was a really nice, quick overview. a question. Well, I think it's clear, but you didn't include malnourished children in this cohort, and would you like to maybe reflect on that?
So we didn't. The controversy about giving any child with severe malnutrition intravenous rehydration is so big and so deep, and they have their own protocol, so they need their own phase 2 trial, and that's what we're conducting at the moment, saying can children with SAM, severe acute malnutrition, be managed on the same protocol as other children. We have 3 arms. We have the SAM recommendations that don't give fluid boluses, give rehydration, preferably orally, and only give intravenous small boluses followed by blood transfusion. If you've actually read the guidelines, compared to WHO Plan C for non-malnourished children, compared to our new recommendation or our new sort of arm of just rehydrating slowly over 8 hours. But the whole thing needs to be rethought, especially that observation that we found that not all of these children have 10% dehydration based on clinical signs, and what our rehydration strategies are focusing on, replacing what is lost. And it's more than they've lost. It's really, so I think there's a big conversation that needs to be had.
Yeah, thank you. Yeah, really interesting, and it's good to emphasize the difference in the severe acute malnutrition, and very excited that there is more evidence in the pipeline that we are going to receive from your group, because of course evidence-based simplification is a bit of a dream, so we're looking forward to getting that to help us. Now, I'm actually referencing a little bit the next presentation, but we have increasing evidence about mortality a lot later than discharge, and it was great that you brought the patients back at 7 days to see that. But I was just wondering if as you go on this journey and you continue with your trials, whether there's any possibility to extend your follow-up, or what is your intended follow-up, given knowledge that's coming out now? Thanks.
So we did follow at day 7 and also day 28, but the ideal follow-up would be to either 3 months or 6 months long-term follow-up, and whether a trial that just focuses on rehydration is the right trial, because what we know from these children is somebody who comes in with gastroenteritis has an elevated risk of subsequently presenting with malnutrition. So whether, if you do design a large trial, you don't just focus on one aspect of management through randomization, you think about other ways of nutritional support that provides, obviously for children with SAM, better nutritional strategies, that thinks about longer term. Modifying the gut microbiome is what we're also thinking about, but also for children who are undernourished, who have gastroenteritis, they do have a risk of being readmitted with malnutrition or dying in the subsequent 6 months. So thinking about some nutritional support for them, that's where we think we need to go.
Great, that's fantastic. Thank you very much. And now I'm going to move on, which is a beautiful segue to once you hear what Moses is going to present. But we have Moses Ngari. He's from KEMRI and the Wellcome Trust Research Program in Kilifi, Kenya. And he's going to talk to us about mortality during and after acute illness among children in Sub-Saharan Africa and South Asia. So I'm going to hand over straight to you, Moses. Thanks. Oh, don't forget to unmute.
Oh, thank you so much. So I would want to start by acknowledging that this study has been done in 6 countries in Sub-Saharan Africa and South Asia. And so I'm presenting on behalf of the Childhood Acute Illness and Nutrition Network. Next slide, please. So despite the global reduction in child mortality, children that get hospitalized and especially after discharge from hospital, they are normally at very high risk of dying from mostly infectious diseases. Existing evidence have shown that anthropometry is a strong marker of risk of death. However, it doesn't show or specify the mechanism of this risk. And so we designed this code basically to understand the mechanism and identify risk groups in order to prioritize intervention and have prioritize intervention for specific targets. Next slide. So the chain code recruited children aged 2 to 23 months, hospitalized or admitted with acute illness in 9 hospitals across 6 countries. The enrollment was stratified by nutrition status using mean upper arm circumference into 3 groups: severe acute malnutrition, severe malnourished, moderate, and not wasting. At admission, we collected the data that you can be able to see on my left-hand side. Then we observed them for the time they were in hospital. And this time we conducted a household survey where we took a comprehensive socio-economic data from the household level. Then we followed them on day 45, day 90, and day 180 after discharge, and then collected a lot of samples that will be reanalyzed. The main outcome was mortality within the 110 days of follow-ups, hospital readmission, and nutrition recovery. But for this presentation, I'll restrict myself to mortality only. Next slide. So overall, we recruited 3,101 children, 1,218 severely wasted, 763 moderate wasted, 1112 no signs of wasting. Loss to follow-up was very low, approximately 3.7%. In total, there were 350 deaths, or approximately 11%. During post-discharge, more than half of deaths occurred in the community rather than during rehospitalization. And as you can be able to see from the survival curve, children with severe acute malnutrition and the highest risk as expected, but the curve is very steep during the first few days, suggesting that the risk is mostly very high during the early period. And this applies to all groups. If you look, even although not wasting children have the lowest risk, but still the curve and the moderate wasting, the curve is very steep during the first few days. Next slide. So our approach of analysis, we perform two kind of analysis stratified by the time points. So the death and day mortality denoting hard deaths, and post-discharge analysis. So for what I present here is results from structural equation modeling, and basically we modifying the UNICEF conceptual framework and look at factors that will be directly impact mortality and the pre-existing characteristics that you can be able to see. The arrows that you see with the continuous line have a direct association with mortality, and then broken lines would have insignificant association. And the thickness of the arrows will show the magnitude of the measure of effect. And as you can be able to see, characteristics at elevation, the nutrition status, increase clinical severity and directly associated with mortality. So HIV and distance to the standard hospital, which is a proxy for access to healthcare. But there are other underlying factors like underlying conditions, nutrition exposures that mediated through nutrition status. Next slide, please. So for the post-discharge mortality, so this includes children that were discharged alive and followed for 110 days. Of course, we have another layer because we have now some data at discharge period. And what came out clearly is abnormal discharge or discharge from hospital against medical care was directly associated with post-discharge mortality. And it seems that almost all factors were actually associated and direct association with duration of hospitalization. but the duration itself was not associated with risk of post-discharge mortality. And as you can see, there were some pre-existing conditions that had direct effect on post-discharge mortality, but others actually were mediated through mostly nutrition status, both at admission and whether they improved at discharge, and clinical severity at discharge, and also direct impact on post-discharge mortality. But obviously they were, okay, thanks. Now next slide. So the main message is raw adiropometry captures many risks besides nutrition intake and could be a good target of intervention. This is the multivariable regression that we presented. Even after adjusting for all those underlying conditions, still you can see the effect of nutrition status. And this one suggests the need to move towards a risk-based inpatient and post-discharge care, where patients that are at high risk are often, some kind of specialized or targeted care, because these are at high risk. The other main takeaway would be when children get discharged, and the other they are classified as recurrent. However, as we've demonstrated and other studies have shown, is that these still remain at very high risk when they get discharged. And so this could be an easy target and would offer an opportunity for reducing child mortality. So we won't suggest having a kind of down referral where children, when they get discharged from hospital, they either refer to nearby clinics or to child community health workers at discharge who can be able to, give them support, and if they need to be hospitalized, they're able to refer them back to the hospital. Thank you.
Great, gosh. Wow, this is really interesting, because it's saying that the children die when we think we've discharged them well, and that's quite difficult, I think, for many people working in hospitals to hear. So, of course, you've highlighted the link to the referral services, sort of, as you call it, down referral. Can you, where you've done this study, can you tell us what's been modified in terms of behavior, either at discharge or with the community? Now that you've shared this data, presumably where you did the work, what's been new, what's changed? What can you advise people in MSF who are discharging people going, oh my God, I've just seen this awful data? What would you advise them?
We would advise having some kind of follow-ups when children get discharged, especially what we've identified as high risk, especially those that are severe acute malnutrition. And these children, when they get discharged from hospital, they have not resolved the malnutrition problem. And so we've ordinarily been referring this to community-based nutrition program. However, we've not been able to monitor or collect data on adherence to this, and we feel that having active follow-ups to ensure that these children actually attend these, nutrition rehabilitation programs, or having them return to the nearest clinics, and probably offering a follow-up referral. The problem, of course, is the financial constraint. When you're telling them to come back, say after 7 days for a review in an hospital, then it comes up with a financial constraint to them that they are not able to come because they can't afford. So the ideal would be, referring them to the nearest nutrition program or dispensary or clinics in the community, and probably having active follow-ups by community health workers. And I would want to mention maybe the use of things like mobile technology. Probably they can be linked where someone can call them and ask them how is the baby doing, that kind of things that is ordinarily not available now that we cannot be able to show up in clinic, just calling them after 2-3 days to find out how their babies doing wouldn't be what they were.
Great, thank you very much. I've just got the notice that there's no time left now more for questions, but I'm asking all the oral abstract speakers to, when this session is finished, to go to the network lounge, because I'm conscious that not only Moses, but quite a few of the earlier speakers had questions that I couldn't ask. So we'll encourage them to network in the network lounge, so you can ask questions directly to them. Now we're moving on to something slightly different. So I'm going to hand over, it's a telesimbox, which is a way to support people to resuscitate well. So I'm going to introduce Elizabeth Sanzo, who is from the Children's Hospital of Philadelphia in the United States and working in the Paediatric Emergency Medicine Department there, and Marie Clarice, and she is one of our MSF paramedical trainers in the Learning and Development Unit. So over to you.
Hello all, I am Marie Clarice, Pediatric Nurse Trainer at MSF OCG, Learning and Development Unit, and I'm co-presenting today this session with Elizabeth Sanzo on behalf of our team listed here and who are with us present today. We are presenting on our experience using synchronous simulation-based learning adapted for remote learners, and we'll start the presentation with a short movie presenting the activity.
Hello, my name is Elizabeth Sanzo and I'm a pediatrician working in the United States at the Children's Hospital of Philadelphia, CHOP in Pennsylvania. We sought to use telesimulation as a way to provide hands-on medical training during a time of restricted travel. So our team wrote 2 simulations on pediatric shock and asthma based on the MSF pediatric protocols and translated them into both English and French. We adapted these simulations into telesimulations based on the ASAP Telesimbox platform and trained trainers working for MSF OCG on how to use the tool. Finally, these trainers piloted the telesims with healthcare workers in Niger. 29 surveyed users responded that they perceived the tool to be effective in teaching the medical and teamwork learning objectives for each case. In addition, they felt that the telesimulations were realistic and promoted reflective discussion to improve their local practices. The concept of remote simulation has rapidly developed in the field over the past 20 years, and educators have demonstrated the ability to leverage telecommunication resources to overcome access barriers in order to reach distant learner groups.
Et dans la restitution, ça permet à l'équipe qui fait les scénarios d'elle-même de ressortir et de se corriger.
It is possible to correct yourself when you follow this.
Easy to use and effective, with the goal to create a sustainable curriculum for use.
Les points positifs de cette télésimulation, ça permet
it has helped us to practice, to have hands-on practice on various cases.
MSF staff in 2020, we are energized to build out the MSF Telesimbox more largely across the institution, with the ultimate goal to improve provider preparedness to respond to a critically ill patient, and ultimately to improve patient outcomes. Thank you so much to my MSF, CHOP, and ASAP Telesimbox teammates for all your hard work with this project, and I excitedly look forward to expanding this work with you all in the future.
Merci. Bravo et à bientôt.
Yes, so the COVID situation stimulates the need to develop new ways of providing support to the learners everywhere, and specifically relevant to the MSF medical workers in the field. This is a way to access peer review and easy to use learning tool wherever you are. So we adapted the telesimbox concept to the MSF protocols. Next. The pediatric team of the Learning and Development Unit, which I'm part of, together with MSF field pediatrician Tanya El Hassan, we adapted the resources booklet to MSF guidelines and make it become a useful tool to make the simulation learning objective. So we decided to launch the experience with a field training team in Magaria, located in Niger, as they are already experienced with in-person simulation. Next. Here is an example of how we set up the distance simulation. So in Magaria, we used 2 webcams plus computer and a sound amplifier and set up a simulation room inside the hospital as you saw in the movie. How that's working. So we prepare together with the facilitator of the simulation, we review a booklet and we define the rules. One nurse facilitator in the simulation room runs the scenario together with a pediatrician as a remote facilitator. The local facilitator set up the room, organize the team on site, and teleconnect with a remote team. The participants are instructed on how the simulation takes place and prompted to assign team roles. The facilitator plays a video, and if the learning objectives are delayed, the facilitator simply rewinds the video so that the vital signs do not progress. Next. Here is a screenshot of the remote facilitator share screen running a simulation with participants together around the mannequin in the Magaria Hospital Pediatric Unit setting. You can see on the right the remote facilitator and observers. We can structure the screen to make the participants' view larger and follow the simulation practice better. I will give a hand to Elizabeth for continuing.
Thanks, Marie. So the trial consisted of 3 days, 1 practice day and 2 full days, consisting of a pre-brief, simulation scenario, debrief, and post-simulation surveys, where we asked the users to discuss the efficacy, feasibility, and willingness to recommend this tool to a colleague. Overall, you see here that the users positively responded to the questions, saying that these simulations were relevant, realistic, effective in teaching the learning objectives, and provided a safe place for the debrief. In coding the free responses, really we found themes that landed in all of those main feasibility buckets. So this curriculum was in demand, acceptable, practical, could be adapted to different situations, and integrated in continuing education programs and expanded across MSF sites and implemented with low cost and easy to do. So really we see this as a way to connect MSF trainers and learners across the globe and really bring to life those MSF pediatric guidelines with hands-on simulation-based learning with remote facilitation. Given the progression of telesimulation as a field during the pandemic, we really see it as a way to break down these simulation barriers and ultimately hope to move the needle on patient morbidity and mortality. We thank you very much for your attention, and we look forward to a wonderful discussion with you all. Thank you.
Great. Wow, that's very innovative, exciting stuff. It sounds brilliant. I want to know, what were some of the challenges? What do you think, if you wanted to scale this up, bring this to other locations, what would people need to think about? How would you expand this good work?
So, Marie, are you on the line also?
Yes.
So do you want to go ahead?
I let you go.
Okay. So this definitely was a team effort, and I'm sorry the entire team could not co-present with us today. That was our best attempt at getting our team represented, just the 2 of us. But really, there were 5 people from OCG Center who really were committed to a 6-month project to develop this curriculum, and Tanya Heshessen, who's currently an MSF pediatrician located on a mission in Iraq. And she really took the bulk of the work to translate these MSF guidelines into this simulation template. And so it required these folks and a committed site to practice these telesimulations with, who had a local champion who really could coordinate the masses, who could get everyone together on a date together, set up the computers, set up the mannequin, and could read the resource booklet and understood the learning objectives and guide the simulation practice with the remote facilitator. So I think what it takes is a team within MSF committed to providing telesimulation education remotely. And what we've shown here is we've standardized a process that can be a blueprint, basically, that can be easily replicable. So you can take basically the entire guidelines any MSF guidelines. We started with pediatrics because we're all pediatricians. And with the right teams from different centers, ideally, you can really start translating this into the field outside of those formal MSF training days.
Great. And some questions are coming in. Let me just check that I say them correctly. A very good question. How feasible is this in areas where the internet speeds are suboptimal? How do you become a tele-simulating trainer? Let's take those two.
Yes, so maybe I can answer to those questions. So that was our main question. So will we be able to make it? And all in all, we did this in Niger, which is not at all in the capital city. And we had to work a lot with the IT team to set up adequate internet in the simulation room. And surprisingly, it works. It works the same way you were able to do some virtual conference with Congo, for instance. So I think more and more the progress in telecommunication will allow us to do such experience. And from our point of view, MSF, we are already doing simulations in the field, but not from a distance point of view. And another adding, which was interesting in this experience, is to have the video of a child record. So when you go from simulation from a mannequin, plastic mannequin, but having a visual of a child video on the screen, that helped a lot the team to figure out what can be the visual of a patient you have in front of you. And it also allows to have some specialists for the debriefing and for the learning of the people participating to the simulation. That was really a great experience.
And we also made sure that the videos that created were available for download on a USB port. So if the local champion on the ground in Magaria, Niger had already been trained, had seen a telesim already done and felt confident themselves facilitating the telesimulation, then they could actually do it on their own. If the internet went down and suddenly Marie could not connect from Geneva, they had the video that they could just play from their USB port, download without the internet, and they had a resource booklet that they could get through, and the idea is that they can facilitate this without that remote help. So we try to design a see one, do one, teach one model, and of course that'll take much more practice and trial to see if it's as easy as a see one, do one, teach one, but we're trying to really break down the basics of simulation education and make it as easy as possible, which would contribute obviously to the sustainability of a telesim program.